Morning, everyone. So I was asked to talk about frailty, and I wanted to get some sort of hook for it. So I posed the question to you: frailty, state, or syndrome? Who knows what this refers to? Who thinks that frailty is a syndrome, a specific syndrome with a few things that are very characteristic? No one? Oh, one person does. Good for you. Two, who thinks that frailty is less a syndrome and more a state, a vulnerability state? Yeah, a girl, Casey. Good. Two, and Roxanne. Very good. Okay, and many other people undecided. All right, so I'll start with some disclosures. I pretty much stopped doing work with pharma individually now, though I did go to a conference in December and a few years ago gave a talk at the AIC. But mostly I've started a company and we do data mining for pharma, and I would discourage any of you from following along that path. Likewise, a couple of years ago, we got involved with an American group who felt that we could commercialize some aspect of the Frailty Index. And so we started a company with them, but it doesn't have any money, and it's been turned down in every granting agency and so on. But for the first time, it was very interesting. Just a couple of months ago, the first time we sent a paper in and got some pushback on it. They said, well, you know, you're just pushing this because you want your version of it to be used. But I want to underscore that we've published in an open access journal how to make a frailty index. I encourage everyone to go and make a frailty index and to use it to your heart's content. So my goals are to review historical aspects of frailty, to outline the view of frailty as a syndrome, and then because that's not really my thing, I'm just going to tell you in general how it works. I'm going to give you more information about frailty as a state. And then because you guys have exams, I thought, what could reasonably be asked on an exam at this stage that could be non-controversial? So I've got a few exam questions at the end. So historically, the idea about frailty came about in large measure. It was something that had a fine point put on it because of the early work done on geriatric assessment. So comprehensive geriatric assessment started to be evaluated as a way to care for older adults during the 1980s. And that was at about the time when evidence-based medicine, as it's now called, was starting to get its foothold. And though it will seem extraordinary to you people, I can recall the days when we had the big thing was about sample size. You had to have a sample size calculation and controlled trials and so on and so on. And all the stuff you take for granted now, each of those steps was quite hard fought. And geriatric assessment was in the midst of all of that. And it was a very interesting example because it wasn't a drug. And we've learned, unfortunately the hard way, we've learned a lot about how evaluating drugs and non-pharmacological interventions is somewhat distinct, and they are not necessarily interchangeable. And some of the rules that exist with respect to understanding how a drug works only obtain to a certain extent when you're trying to understand how a non-drug intervention works, particularly a multi-component one. So one of the early questions that needed to be addressed in the first days of this was, to whom should a geriatric assessment be offered? Because it was evident to everyone that there are lots of older adults who are quite well, they're fine, and there were other ones who were not. And so the idea was put about as to how to deal with them. Frailty was posed as an early candidate. It was rejected because some people said, look, a lot of these folks are too frail for us to help, and we really shouldn't get involved with them. And various terms were bandied about during those days, including one that went along for a couple of years called the targeted elderly. Who are the targeted elderly? The people who are the targets of a geriatric assessment. Who should geriatric assessment target? The targeted elderly. And even though that was clear, that is clearly a tautology, that went around for a couple of years. So it took a while for things to get sorted out. Canada had a disproportionately big role in this, and the work of David Hogan, then at Dalhousie, and Roy Fox was very key in establishing the basis of a geriatric assessment in consequence of 2 randomized controlled trials that they published. And so when I moved there to do my training in 1990, the trials had been done at that point, but the fight was on about how to understand that. And that was one of the ways that I kind of got into the frailty issue. The dominant understanding of frailty in the world right now is that frailty is a syndrome, and it has been promoted by people at Johns Hopkins and Linda Fried, who is now at Columbia, was the person who, more than anyone else, tried to bring together the thinking about this. And it arose in 2001 in a very particular context. And the context was to try and get something that was clearly identifiable by doctors, in large part because the thought was if you did that, you could bill for it in some way. And they were also very keen to not replicate work on disability, to say, let's not take the disability stuff and rename that as frailty. And some groups had done, including our group in the old days. So when I started off doing this, I understood frailty to be a complex state where a lot of things went wrong, but it became important. It had meat to it. People became the targeted elderly as they became more and more dependent. And disability often goes with that, and that was how we sort of came at that. So they were keen not to do that. They were keen not to reproduce the idea of comorbidity, and they've been very successful in that. In fact, one of the issues right now in terms of the new incoherence in geriatrics is the notion of chronic multimorbidity. And if anyone has questions about that, I can come to those at the end. I won't say more lest I get off in a rant. So the idea that, I'm not checking my email, I'm trying to find out what the time is. So the idea is that, that frailty arises in the context of aging. And so this model is put forward where it starts with aging. They see a very important role for the musculoskeletal system. They see how this impacts as well to get sarcopenia, which according to this model is a very key aspect of things. The resting metabolic rate decreases. With that, total energy expenditure goes down, as we've heard of this cycle and so on. They have circles in here to show that these are nonlinear relationships. This is a model of frailty that is proposed, and people at Hopkins work on various aspects of this. And to give them their full credit, I've been for several years now on the external advisory committee of the Hopkins Older Americans Independent Center group that does this work. So even though it's often portrayed that Linda and I fight, we disagree, but we've worked and we've talked about these things for a long time. And that's very instructive, because one of the hallmarks of being part of our tribe of geriatricians is we generally get along. That's why we're happy. So I've characterized the frailty phenotype as operationalizing frailty by items that are highly specified. But where there is great agreement is, back in the old days, the frail older adults are older adults who are at an increased risk of adverse outcomes compared with people of the same age. Commonly, we test this by looking at the ability of measure X or measure Y to predict mortality. But that's just a convenience. That's because mortality in this age group is not uncommon and binary and non-arbitrary and relevant. But there's nothing special about it. If we were going to do it, many of the models would have to include age. And so if you want a hint about whether you're seeing a claim about a new frailty measure, and at the last GSA, there were 22 new frailty measures introduced, but they all more or less conform to one of two views. Frailty is either a syndrome or a state. So if you want to get a hint about whether this new one is worth anything or not, look at the portion of people in this group who have died. And if it's small, if it's under, say, 20%, the estimates are unstable. So you need to have a group in which, if mortality is being used as an outcome, it is quite common. The other thing you need to take into account is not just the relationships between the items and the chance of dying, but the area under the curve that's been explained there. So these are just a few hints. And also, if you see that they've included age in their frailty measure, stop reading, move on. So, so variables in the frailty phenotype approach, trying to still get at the central core of frailty, is the increased vulnerability to adverse outcomes of people the same age. That's what the idea is. They've specified, as you all well know, slow mobility, weakness, weight loss, decreased activities, and exhaustion. And various other groups, including Howard Bergman and David Hogan, have said, we should add more to this, and the two major candidates are cognitive impairment and impaired affect. And then intelligent people, goodwill, dispute in the way that academics do precisely how to measure impaired grip strength. Which hand did you use it in? Which dynamometer did you use? How did you standardize it? And so on and so on. And you'll see people come to blows about this. Well, they would, except they're geriatricians. We don't do that. If we were cardiologists, though. So that's one view, highly specified, fight about the actual items that are involved. The other view that we've taken is that frailty reflects aging, and aging is the accumulation of deficits, and it begins at the subcellular level, and it scales up. And so it doesn't really much matter what you count, we say. Just count things that are wrong with people. But the trick is count a lot of them. So we've said now you can't just count anything at all. You should count things that increase with age and that are bad for you. So say if blue eyes turn out to be bad for you, and as far as I know they're not, then we'd say we won't count that because your eye color doesn't change with age, because we're trying to get at the aging component of it. In the same way, if it increases with age, it also has to be bad for you. So gray hair, for example, increases with age, but it's hardly bad for you. In fact, some people might argue that you have more credibility with it. Did you know that amongst the pilots, amongst the flight crews, when things are going to bounce up and down, and flying often, things are going to bounce up and down, it gets really hairy, one will look at, one of the flight attendants will look at the other one and say in a reassuring way, it's okay, there's gray hairs up front. And that's what they mean. So, yeah. So we certainly wouldn't count gray hair as being bad for you. And what we say is that if you're going to count something, you should have fewer than 5% missing data. And because there's such a large number of things that are out there, if you've got one variable with a lot of missing data, don't bother with it. And to read between the lines, this is a sly dig at the people who use performance measures, because commonly the amount of missing data there is in the range of 15, 20% or so. So we say, you can fight over the grip strength thing, but it turns out that people can't lift it up, or they won't do it, or someone says they're not safe, then that becomes uninformative. And then we say, take that number of things that you've got and divide by the number of things you counted. And for any individual, that's what their frailty index score is. So to say it again, the number of deficits present in an individual divided by the number that you counted in general for this group. This is because commonly if you have a database around, you have a lot of health data in it that are candidate health deficits. And most electronic medical records have the basis for it because they have comorbidities. But it's more than that. You have to get into the expression of impairment, which means you have to have some information about function. And it looks like it's best if you have some information about cognition as well, and something about health attitude. But these are not mandatory. The number of things you count is quite large. So let's say then that we've got a data set to hand. You did this study for your project and looked at 122 people with delirium, and you measured a bunch of things on them. Do you have a frailty index in there? Well, you might if you've got enough variables that meet those criteria. And so say that you had 50 of those, and then the person in front of you had 10 things wrong, then their frailty index score would be 10 divided by 50, which is 0.2. And that would give you some insight as to what happens here. So the idea behind this is that we're simply trying to get at variable vulnerability that arises as a consequence of some people being biologically older than others, or some people having more things wrong with them than other people do. And it turns out that virtually anything that you want to look at becomes more common anything bad you want to look at becomes more common as people get older. And this sometimes puts us at odds with the sociology types who say that we're just playing on stereotypes and whatnot, and we're not, we're just counting. And so let's take, say, vision problems. So when you're young, very few people have vision problems. After the age of about 40 or so, it starts to go up. And then by the age of 65, there's no one left with normal eyesight, more or less. Mobility disability follows the similar pattern, except it starts sooner. Arthritis, not quite so much, starts sooner, goes up more. Thyroid problems, the blue graph is women, the green graph is men. So the blue line here shows that women have thyroid problems more commonly than men do. And so you can just go through and get a whack of these. And what happens is that when you take the average of all those things that go up, you get a line that looks like this, that it's, we're going to ignore this part of it right now, but you have a line that looks like this, that things accumulate with age on a log scale. And this is very convenient and also revealing to us because this isn't actually the frailty index. This is the relationship between age and mortality. Age, mortality. So, and this is the famous Gompertz curve described by Gompertz in 1828. So, you know, hard to build a career on this now. But if I show you now the data from the National Population Health Survey in Canada, with each line representing a different wave of the survey from 1994 on, you can see that it looks strikingly like and statistically fits the same family of curves that the exponential curve, which relates mortality to age, is. And we think that it is like that for a reason. We think that there's much change over time for a reason as well. And these are exciting observations when you start to drill down on them. So it's not exciting to say, you know, the older people are, the more things they have wrong with them. And even over time, even over the last 20 years, that hasn't much changed. No one's going to go down and say, isn't this amazing? We can start to look at some of the things that you can understand about the Frailty Index. It becomes rather more intriguing. So this is work from Melissa Andrew, whom you'll hear more from tomorrow, or I think it's Saturday. What she did was to use data from, looks like the Canadian Study of Health and Aging. She counted 40 items there and showed that this was the shape of the Frailty Index. And I want to draw your attention to a few things. Number one is that this is skewed. So this is just the density distribution, you know, the count, right? So a few people had not much wrong. The mode was to have a few things wrong, and almost no one had a whole bunch of things wrong, right? So when you get to be older, there are some people with not much wrong. There aren't a lot of them, but there's very few people as well with a whole ton of things wrong, because it looks like there's a limit to the number of things that you can have wrong with you. The other thing which is very interesting is that the shape of the distribution within an age population varies very characteristically, so that if we look at young people, children actually, 45 to 50, we find that about 40% of them have nothing wrong at all. But by the time people get to be age 80 to 85, almost everyone has at least one thing wrong with them. And this shape changes very characteristically. Whoops. Now I've done something I shouldn't have done. I keep doing something I shouldn't do. I want to go the other way. Uh-oh. Yeah, I'm way ahead. Yeah. Previous. There we go. It's painful, isn't it? See, people work with slides that they really shouldn't. Previous again. And again. This better be good, eh? When I go that time. Ah! Okay. What I was trying to show you. Oh, good. Thank you. Some competent person. I had a mouse here. What I was trying to show you was that the shape of the distribution of the curves is very characteristic. I can write a slide again, but I'm going to stop and push ahead now. So what I'm trying to show you is that the shape of the distribution of the curves is extremely characteristic. And anyone here done math, by the way, undergraduate degree in math, computer science, engineering, physics? No one? I want to say someone. Not a single person? Okay, anyway. So then you might not be able to say, wow, that looks like a Poisson distribution. And it turns out that it is. And it turns out that is one of the ways that this approach is powerful in terms of informing us about the distribution of the curves allows us to make inferences about the mechanisms that are involved. And that is one of the reasons we're persisting with this. So, so one of the things which is also very characteristic is that the frailty index is higher in women, here in red, than it is in men, here in blue. At any age, women have more things wrong, have a higher frailty index count than men do. But does that mean that they're frailer? And you can argue yes. And if we think that frailty is the increased vulnerability to adverse outcomes people of the same age, then the mortality data would suggest to you that older women are not frailer than older men because they tolerate their deficits more. So there's the mortality curve, which I've now put on a natural scale, showing that it increases in relation to the value of the frailty index more in men than in women. Normally when I give this talk, I pause now to say, so if you're aware of the phenomenon of a man cold, right? Got to take that seriously, right? You women may be able to slough that off, but it could kill us without appropriate care. Because we just don't tolerate these things as well. So one of the questions that comes up then is, isn't it a lot of things to count? Isn't 50 things a lot of things to count? Surely to God, we don't have to count 50 things, do we? And you know, I say to people, it depends, right? If you're a cardiologist, that would be 47 things too many. Troponin and two other things which are arbitrary. So it depends on what you're trying to do. And it turns out that within geriatrics, we tend to count a lot of stuff. So this is a one-page condensed version of the geriatric assessment that we use in Halifax. And the geriatric assessment we use in Halifax is now all on a single page. In about 10 years, it'll be on an app, I guess, if our hospital will let that happen. And the idea is that the items which are here are the things that you would ordinarily do in the course of a geriatric assessment. You inquire about cognition and emotional status and mobility and balance and bowels and bladder, nutrition and function and so on. And it looks like a lot of stuff, but we do it virtually effortlessly all the time. And it turns out that if you now take this comprehensive geriatric assessment and make a frailty index out of it, count the deficits there, and make sure all the rules are followed, and so on and so on. That one that I just showed you has 70 items in it, and 70 items which are put there are now. This is again some data from the National Population Institute of Health and Aging of a frailty index based on a geriatric assessment, and look what happens there in people aged 70 and older, 2,914. And their 5-year survival is very good if the frailty index is low. But the 5-year survival is very low if the frailty index is high. In fact, at a frailty index of 0.5 or higher, there is 100% mortality by 22 months. So I'm going to play the proud father here now. This is me, this is my son, who's an engineer in graduate school right now, and when he was doing this work with me, he said, Dad, I'll show you something very interesting about this. This is a radioactive decay curve. This is a system that has no ability to repair itself, and this is how it fails. And isn't it the case that the 0.4 and the 0.5 curves look to be about the same? And a line of inquiry right now is going on in a program we call the Physics of Frailty, trying to evaluate this in a formal way to look at what inferences can we make about the redundancy of systems based on the shape of the distribution of these survival curves. And so I want to show you what I think is the coolest thing we've found out so far. You probably wondering, I said, what's the coolest thing you've done so far? This is the coolest thing that we've done so far. So I was very keen on the idea that there's a limit to frailty. And so the frailty index, the lowest score you can have is 0. Don't have anything wrong. 0 will be the frailty index score. But if you counted 100 things, who knows what the highest frailty index score would be? Casey knows. Tell us, Casey.
It's around 0.7.
Around 0.7. So it would be about 70 things. If you counted 100, there would be 70 things. If you counted 50, it would be 35. And this is quite robust. And we've looked at this now in more than 300,000 people from around the world. And it turns out that it looks like there's a limit to frailty, and it's about a frailty index of somewhere around 0.7. So I was very keen to come up with a severe test of this, right? Because if this is true, it's very important. It tells us that we can quantify frailty from a geriatric assessment and have some insight into how frail someone is very precisely. And so I was fortunate to run a thing called the Canada-China Collaboration on Aging and Longevity. And so we, through that, had access to the Chinese longitudinal health and longevity study. And we used that to look at the outcomes of people aged 85 and older, actually 85 to 99. If we have the 100-year-old data in there as well, it doesn't change anything, just that the boundaries of the world literature are prowled mercilessly by people who fancy themselves as centenarianologists. If you're not one of them, you pretty much can't publish. So we said, oh, fine, we'll just drop it then. We'll just do this for age 85 to 99. So it being China, we could get a survey with 6,600 people like this. And here is what happened the first time out. So if you look at the distribution of the frailty index at baseline, there were actually a few people out of the 6,600 who said they had nothing wrong with them, but mostly it was the case that people had frailty index around 0.15. I got to stop touching this. It's so good. Oh, I can use the up arrow? Oh, are you ever good? Fantastic. Isn't this great? Thank you. Okay. So what we showed was that that at baseline, you can see that the curve is peaked at a frailty index around 0.15. If you go back 2 years afterwards, you see the area of the curve is a lot smaller. Where have those people gone? They're dead. But the mode has not changed. You go back 2 years afterwards, it's smaller again. Where have they gone? They're dead. And you go back 2 years again, they're dead. So almost no one is left from the original starting cohort 8 years afterwards, right? No one's left. They're all dead. But look what's happened to the mode. The mode has stayed about the same. And the maximum has never been exceeded. So it's not the case that people are shifting over bit by bit by bit. There is a process which is invariant, which plays out such that there is a characteristic mortality associated with frailty. And that, I think, is the coolest thing we've found so far. And motivating further inquiries by our group is the catchphrase that we use. So on the bottom, you can see what the proportion distribution is. So the proportion distribution of this is about the same everywhere. And so we're doing a bunch of work on that now. Now, you might say, okay, well, you're counting a lot of things, and people get worse over time. How does this play out with respect to a given individual? And I want to draw attention to this for you now. You can see that some people get more things wrong with them over time, and some people have fewer things wrong, and some people are stable. Some people, things go up at a very high rate, and often you'll see with them, there's only 2 points on the curve there because they're dead after that. And sometimes things go up generally. So even though the average line is going up a small amount, which is what this line is, there's a lot of variability there. And the variability looks difficult to get to grips with. But look at this. This is how the variability, this is all that information now played out, and we look at the outcomes in 2 years' time, or 5 years' time, in this one, given the starting state. So if you had only 2 things wrong with you at baseline, right? If you only have 2 things wrong with you at baseline, then the chances are that you'll have 3 things wrong at follow-up. A few people will have 1, and even with only 2 things wrong, almost no one's going to go back having nothing wrong with them. You can see that that the shape of this distribution for 2 things wrong, 3 things wrong, 4 things wrong, and so on, is extremely orderly. You can also see the area of the curve goes down, because people die the more things they have wrong with them. So it's this extremely orderly shape of the distribution, which is really motivating why we're really keen on understanding frailty as a state, because it doesn't really matter what you have wrong with you. It seems it's a number of things that you have wrong with you, which is the big picture. So even though it's extremely important for us as internists and whatnot to understand, well, what exactly do they have wrong with them, right? They've got a kidney problem. Really, which one? Well, it's, renal tuber acidosis. Really, which one? Well, it's type 4. Really, which one? Well, it's type 4B. Okay, well, now I'll stop, right? I mean, we do need to know this to look after individuals. But to understand the big picture, we're going to watch the number of things people have wrong with them. So I sort of say rather snobbily now, you've seen the other model. This is our model. It's written in a particular form. Science progresses when you can quantify things. And the items in here have a very particular meaning, and they are clinically translatable and allow us to start to frame our inquiries around why certain elements in that model change in the way that they do. Each of them has a covariate and so on and so on. This is what it looks like in people. These are people from a different survey, but the red dots are mice. And so mice appear to accumulate deficits in the same way, if you normalize age, that people do. So it looks like this is a way to understand aging. It also turns out to give you information. Remember I said that the items in that equation each have covariates that can be associated with them. You can understand the outcomes in relation to how covariates change. And at the big picture area, you can see now that this is the mean level of frailty index in association with gross domestic product, right? So anyone here from Poland with Polish ancestry originally? Oh, there must be someone. Yeah, Roxanne. Roxanne cannot be the only person here. There must be someone else. No? No one else is claiming Polish? Too bad, Roxanne. But look, in Poland, the GDP on the x-axis is low and the mean level of frailty is high. The mean level of frailty index is high. And in Switzerland, anyone here so boring to be Swiss? Loves the chocolate? Okay. Their frailty index, mean level of frailty index is low and the income is high. And it turns out that the correlation is around 0.73. So we think that it also allows us to understand what's happening in the big picture as well, and a couple of the terms in the equation fit with that. That was 0.8, there you go. So low-income country, high-income countries, blah, blah, blah. So, now, as I finish up, I want to show you how other people have tried to look at this work. So there's recently been a largish study out of Newcastle published by Collerton and colleagues in Mechanisms of Aging in June 2012, and they wanted to look at the relationship between the frailty index approach and the frailty phenotype. And either the top or the bottom graph will do. This is easy to understand here. For people who had very few things wrong, who were all aged 85, so this is a cohort of people where the youngest person is aged 85. For people with few things wrong at the age of 85, about half of those were robust and half were, in the Freudian terms, pre-frail. And almost no one was frail. And the prevalence of frailty increased, the portion of frail increased, and somewhere around 0.25 becomes non-trivial, and the number of people who are well at that point becomes trivial, and so on. So we're getting at many of the same constructs. We're getting at many of the same general understanding of things. And there will be circumstances under which it will be very convenient to only have 5 things, and or 7. And the circumstances under which it will be convenient to count past 7 to really understand what's going on. And so we're not talking apples and oranges here, but there are some important differences. Now, I'll finish that, like I said, I promise you, with some points for the exam. So here are some things I think that you could be asked about in which the answer would amount to this, and it would be non-controversially true, apart from the contrarians. So frailty refers to the increased vulnerability to adverse outcomes of people of the same age. True? I don't know anyone who would disagree with that. Frailty is associated with a range of adverse outcomes and not just mortality. And that's important when you read the literature on this, because we're also trying to predict future adverse outcomes, including worse health, more disability, and so on and so on. Frailty becomes more common with advancing age and appears to be related to fundamental mechanisms in aging. Everyone says that's so. Older adults, now identified as frail, have been shown to be the chief beneficiaries of specialized geriatric interventions undertaken under the rubric of, quotes, comprehensive geriatric assessment. I've skirted around a number of controversies within the geriatric literature by wording it in this way. You could word it slightly differently and people would fight about it, but I think everyone would say that this is true. And one point that we haven't much made, but I'm happy to take questions on, is frail older adults are more likely to demonstrate classic geriatric giant presentations of acute illness for reasons I will elaborate upon if asked. So no one does work like this alone. I've been extremely fortunate to work with a large number of people here, particularly Arnold Minsky, the mathematician with whom I've worked since 1996, and have been funded by a large number of agencies. I thank all of them for their contribution and you for listening. Thank you. So I've left some time for questions. Who has questions?
In practice, if one considers our population and take account of their number of chronic diseases or number of medications, can we feel confident that this is a marker of the frailty?
So
there air to define frailty?
Right. So thank you for that excellent point, because it gets at the issue around some of the new confusion within geriatrics is the simultaneous existence of a concept called frailty and another one called chronic multiple comorbidity. And chronic multiple comorbidity has come about as an unintended consequence of frailty being seen as a syndrome, because not everyone with frailty syndrome has chronic comorbidity. And not everyone, though most people with chronic comorbidity are in fact frail. I have some data on that. It's like, this is the Okay, so I have some data on this which speaks to the point that not everyone with chronic comorbidity is frail. There we go. So these are data from the these are data from the Study of Health and Retirement in Europe and people over the age of 65. And you can see that there's this whole idea we need to disentangle frailty from comorbidity and all sorts of stuff. But most people who are frail are both disabled and have high comorbidity. And it doesn't really matter how you define frailty, that will be so. And in fact, somewhere around 90 to 95% of people who are frail have either they're either disabled or have comorbidity or both. So a lot of the disentangling story is bogus. But the problem with focusing on the comorbidity alone is that it really undercuts what we do because we're about function, right? Because people can have a bunch of things wrong with them. In a sense, we don't care. We only care to the extent that it impacts on their function. So as a rule of thumb, you saw someone who's got 15 things wrong and 22 mad chances are they're frail, very high. But we shouldn't call that frailty because that is undermining what our understanding of it is. And the other thing is that the mathematics of comorbidity do not mimic the mathematics of frailty. So if you came up with frailty index, which is comorbidity only, you'll miss out, you'll greatly reduce the ability to predict adverse outcomes. Yes? The clinical frailty scale. So it seems to be widely used. There's a 7-point version and a 9-point version as well, a 9-point version of it. So who knows what the clinical frailty scale? I didn't talk about it here. Okay, so it was published in the CMAJ in 2005. It was based on the Canadian Study of Health and Aging. It was originally a 7-point scale, in which 1 was you were very fit, and it went down to 7, which we combined frailty and terminal illness. The 9-point scale distinguishes between severe frailty, very severe frailty, and terminal illness. And it looks like it's fairly convenient. I think the advance that we will make with this is because we've now got little pictures that go with the clinical frailty scale. So when someone is very fit, the wee picture of them is someone doing this. And when someone is quite frail, the picture of them, I'm doing that. And you'll hear from Judah Goldstein on Saturday, who's a paramedic who did his PhD with me on the pre-hospital assessment of frailty. And it turns out that the screen is something you can give to families with the wee picture on it, and they can get then a sense of what, they can tell you what the person was like 2 weeks ago. So that's what the standard is. We've been trying to introduce this in a variety of settings: orthopedics, cardiology, the emergency department, and so on. And I've met with less success in Halifax than the published literature from other institutions would claim that so. So I think it has a good future. It's just best to bring it in from out of town. So, so you're not from Halifax, so you should have, it should be fine for you to use that. Don't tell anyone. So, so we think the scale is quite worthwhile because you can look at it at a glance and sort where someone is. And it gets at the pragmatic point that if you look at an older person in the emerge, right, they all look the same, right? Where they could have been fit 2 weeks ago, frail 2 weeks ago, and it's very hard to tell. It'd be a great project for someone, by the way, if they wanted to. If they were going to spend a couple of years at a place that was really keen about this. You could look at the physical signs that go with advanced frailty and see if you could just tell by the exam whether someone is frail or not. But if you got the wee picture there, that undoubtedly will be better. Yes?
Well, I guess I'm just curious now. By definition, then what you're trying to describe to us is that every patient that comes into our geriatrics clinic for a comprehensive geriatrics assessment is essentially frail. Not to minimize,
right.
Like not to minimize it, but that's essentially because they're being referred because they're in a state of frailty, or they have, however you want to define it.
Sure.
A number of factors on a frailty index, or a number of medical comorbidities. Maybe that's not the best way to define it, but those are the people that we're seeing in our clinics, right?
Right. So the question then becomes, how frail are they? And are they frail in ways that allow us to intervene? Or are they frail in ways that undermine what we're aiming to do? And what for that individual is the cause of their frailty? And how much disability they have, and so on and so on. What I think that the frailty index adds to a geriatric assessment is a number. And I think we'll be better off when we get the numbers and understand the behavior of them, right? So that, I think, is where the future lies with respect to this. But the symposium we're doing on Saturday says frailty in geriatrics, our burden or our glory, right? And we need to think of it as our glory. And we need to understand that we are the frailty doctors. And the thing about frailty, I mean, the real thing about frailty, what should motivate us, is that the skill set you need to look after a frail older adult is not the skill set you'll get any other place other than with us, right? Looking after frail older adults is just like peds, right? They're not small. So children are not small adults, and frail older adults are not collections of people with one thing wrong, and we just identify the one thing wrong at a time approach. So what we do is we identify the integrated measures. We identify the things that are close, that are signs that our person is close to whole system failure. And we manage those in a way that's less harmful and more beneficial than treating them as though they're a collection of a group of people who have one thing wrong. And we're going to treat those one at a time, which is the way that I was taught, right? Not how to do geriatrics. You had to do internal medicine. You had to soap the notes, right? You had to have the problem list, and everyone's subjective, and that's bogus. That does not work. And what you need instead is to look at the factors that integrate an older individual's ability to maintain function and deal with those. And that's really what we do within geriatrics.
Last question, and it might be, I'm not sure, maybe I just didn't understand. But one of your earlier slides, you went into the fact that women for a given age, male and female being the same age, women will have a higher frailty index because they have more problems, but they seem to tolerate it better. But then in some of the later slides, you just showed the frailty index, and you showed how people with higher frailty indexes just drop off the curve. So I was just confused if you have to stratify that by sex or how you reconcile.
Yeah, the more things you have wrong with you, the less the sex difference will matter, right? So it will still be the case that you can look at the survival curves. Women will live longer than men do, but the shape of the curve won't change, right? So, and it's really the shape of the curve which allows you to make the inference about the degree of instability. So at the end where it looks like the radioactive decay curve, it'll be slightly more beneficial for women than for men, but the shape of the curve will be the same. But I mean, that's an excellent point. The other thing which our group spent a lot of time thinking about is if a lot of the inference about the individual comes from the shape of the curve in terms of their population attribute, how do we make that scale? And if the deficit count is mediated by the circumstance of sex, are there other circumstances which mediate the deficit count as well? And it appears that there are, right? So the deficit count is not destiny. That's why the number, if we count with the number, it will still need to be interpreted, just like hemoglobin, right? If you've got hemoglobin of 180 and you're from Denver, that's fine. If you're not, then we think about other things you might have wrong with you. So the number will always need to be interpreted, but the number will still be very determining when you know what the context is.
Thanks very much, Kim.
You're most welcome. I will try and advance.
Agreed to do this talk on extremely short notice, like within 48 hours of notice. Joanne is a geriatrician and a clinical pharmacologist. She trained both at UBC and in Toronto, and she is currently a member of the Clinician Scientist Training Program, completing her master's in clinical epidemiology here at U of T in the Institute of Health Policy, Management and Evaluation, and she's also a research fellow at the Li Ka-shing Knowledge Institute at St. Mike's, and she uses systematic review and observational methodologies to study adverse drug reactions in older patients, and also works with ICES, the Institute of Clinical Evaluative Sciences. So take it away, Joanne.
Thanks, Barb. Good morning, and today we're not going to talk about drug-drug interactions. I understand there's 45 minutes, so I hope everyone's had a little bit of a snack and has their juice with them, because we're going to go pretty quickly. So we're going to talk about drug-drug interactions. There's really two main categories. One is pharmacodynamic drug-drug interactions and pharmacokinetics. We're going to walk through them, and I'm also going to give you some practical tips. So an adverse drug event is really any injury that results from the administration of a drug. I like this very broad definition. And older adults are at increased risk for adverse drug events. So Lazaru and company, I think, did a review of the literature looking at adverse drug events among kind of hospitalized patients and among general hospitalized patients. So this is peds, oncology, surgical patients, but 6.7% of patients, all right? But when you actually look at the geriatric literature, European studies have kind of described 20% of older patients admitted with adverse drug events, and among long-term care facilities, patients in long-term care facilities, upwards of about 67% of patients may experience an adverse drug event. So fairly common. Often our patients are not included in randomized controlled trials, but really that doesn't really prevent us from prescribing those medications to these patients. Some literature has described kind of 2/3 of ambulatory patients greater than 60 years of age are on 4 or more medications per day. And that's one nice way of kind of estimating the issue of how many patients are on how many medications. But when I did this study through ICES, just looking at Ontario outpatients that were having a colonoscopy. So this could be screening colonoscopy, it could be, symptom-driven colonoscopy, but they're outpatients, so they're relatively well. The median number of medications was 9 per day, okay, with the interquartile range of 6 to 14. So our patients are on lots of medications. So I'm rediscovering Dr. Zeus with my 3-year-old daughter, and I came across this wonderful picture of an older gentleman here who's in front of a big tray of meds. I take 3 blues at 8:30 to slow my exhalation rate. On alternate nights at 9 p.m., I swallow pinkies, 4 of them. And I'm sure if we go around the table, it doesn't matter what stage of training or how many years of practice you've been in, I think each table would have at least 1 or 2 good stories about patients that have, been combining their medications, maybe trading them with their significant others, maybe putting them in a pretty candy bowl and just taking whatever they feel like that day, or just getting them mixed up and confused. And I don't blame them if I was on that many medications. So, in terms of terminology, pharmacodynamics is what does the drug do to the body? It's a result of the drug-receptor interaction. Pharmacokinetics is what does the body do to the drug? And really, we often describe this in 4 stages: absorption, distribution, metabolism, and excretion, or elimination. So as we get older, if we don't have any diseases, which would be very lucky, but just with normal aging, there are changes to our pharmacokinetics. In the absorption phase, which is getting the drug into the body, in terms of clinically relevant kind of changes, the stomach environment is less acidic. It may affect the absorption of certain drugs. So now that the drug is in the body, then distribution is where does the drug go in the body? Okay, and we have different compartments in the body. There's fat compartments, water compartments, there's just the plasma, and different drugs can go in different places depending on how big they are, how much they like fat, how much they like water. And as you get older, the proportions of fat and water do change. And this does affect certain aspects of medication. So for example, fat-loving drugs, the proportion of fat increases as you get older, okay? So there's almost, you can think of it as it's a greater reservoir in your body for these fat-loving drugs. It actually takes longer in order to metabolize these drugs. So some drugs, especially your fat-loving ones, for example, zopiclone, some of your benzos, will actually have a longer half-life as you get older. Conversely, the proportion of water decreases, okay? And this will also alter some of the effective drug concentrations for your water-loving drugs. An example might be digoxin, water-loving drug. Because there's essentially a smaller water compartment, if you will, if you give exactly the same dose that you would in someone who's, say, 50 years old, you may effectively have a higher drug concentration and run into some difficulties. So next phase would be metabolism, which is processing of the drug. So how does the body kind of metabolize the drug? And we tend to think of 2 phases, phase 1 and phase 2. As you get older, phase 1 decreases in general by about 30%. And finally, now that the body has kind of metabolized the drug, let's get it out of the body. So elimination or excretion. It's predominantly renal. And as we know, as you get older, your kidney function will start to decrease. So this just happens if you're aging normally. And then we can start to throw in and introduce some comorbidities and other things. And then you can end up with definitely a different profile when you handle drugs. So let's talk about pharmacodynamic drug-drug interactions. This is when the effects of one drug is changed by the presence of another at the site of action. Okay? So there's 3 big categories. One is synergistic. So that's when drug A plus drug B equals greater than the effects of what you would expect from just a simple summation of drug A and drug B. An example would be a little bit of ethanol, a little bit of barbiturates, and you can be extremely CNS sedated. Can anyone think of another one, maybe a positive synergistic drug-drug interaction that we may use, maybe to treat endocarditis? Don't be shy. So, for example, gentamicin, exactly. Thank you, Justin. So gentamicin and penicillin, if it still works, or Amprovanco, whichever one you want. So that would be a synergistic. So those 2 antibiotics have a synergistic antimicrobial effect. And we commonly use that when we treat endocarditis. Additive would be another drug-drug interaction. That's when drug A plus drug B equals the effects of drug A plus drug B. That's what we tend to expect. So, for example, in the postoperative period, we may prescribe acetaminophen, hydromorphone, and then you may not need so much hydromorphone because you've got some acetaminophen to kind of provide a non-opioid kind of analgesic. Can anyone think of a negative additive drug-drug interaction? Maybe hyperkalemia. So how many ways can you give me hyperkalemia? I'm going to start pointing at people soon. Give me an example of 2 different types of drugs that if you take them together can give you hyperkalemia. Perfect, thank you. So ACE inhibitors and spironolactone, both of them can cause some hyperkalemia. Put them together, you have a higher risk of hyperkalemia. Perfect, thank you. Antagonism. So this is when you have drug A plus drug B equals less than the effects of this, what you would expect from drug A plus drug B alone. So an example would be donepezil, which is a cholinesterase inhibitor, and oxybutynin, anticholinergic medication. Can someone give me another one? Say with Parkinson's disease. Someone who's on levocarbidopa is also on, thank you, metoclopramide, antipsychotic, many different ones. So exactly, so we see pharmacodynamic drug-drug interactions fairly commonly. So pharmacokinetic drug-drug interactions is when one drug affects the levels of another drug. So here, is there a pointer? Mousepad? Mousepad, touchpad. There we go. All right. So here's your chronic medication. These are the drug levels. And let's just take warfarin, for example, an anticoagulant. You just want it to be right at the perfect level. You have too little, you clot. Too much, you bleed. Okay? So you're doing pretty well. You know, you're super stable. You're taking your warfarin. Everything's awesome. And then you take a new medication. This medication happens to inhibit your metabolism. So then you're not metabolizing your drug as much. Higher levels of drug. And then you get toxic. You bleed. Or, say, the new medication is rifampin. And so you're actually inducing metabolism. You're metabolizing more of this warfarin, so your drug levels go down and you clot. So how to keep track? In medical school, they told me, which was a long time ago, I guess, now that I think about it, they said, know the drugs you prescribe. And I'm like, okay, sure, but it's actually a lot easier said than done, especially when you're faced with a consultation for a patient and they've got 24 distinct medications right there. The other thing is, you know, what about clinical significance? I mean, are all cytochrome P450, 3A4 substrates created equal? Are they all kind of at equal risk? We'll talk about that. One of the resources I like to mention, because I find it quite, useful, backwards, is the Flockhart table from Indiana University. The website is www.drug-interactions.com. It's free, it's not drug sponsored, and it's pretty good. It comes up with different tables, basically as tables for all your different cytochrome P450 enzymes, and it tells you what's a substrate, inhibitor, and an inducer. And I just pull up the website when I'm working if I don't know what's going, if I'm not sure if there's an interaction. I use the search function on my page, and I look up the different drugs that I'm really interested in, and then I'll just highlight it. Very quick. And then at least you know, and eventually you'll learn them, you'll remember them. There's also a clinically significant, where's the mouse? Right there. That's the link there, that you can print out. It's a PDF. But just remember, if you're going to write anything down, just write this down, okay? So feasibility, it can get overwhelming, but it's okay. We'll tease it out. So there are a couple tips when you're prescribing medications in terms of trying to prevent drug-drug interactions. So one is, you know, maybe picking drugs or just being aware of drugs where we diversify the metabolism. So kind of makes sense, right? Like if one drug is entirely metabolized by just one pathway, you ding that pathway, that's it. You're going to be left with a lot of extra drug. Say, for example, olanzapine is metabolized by, anyone know? Cytochrome P450 1A2. Okay, and that's it. You ding that, and then you end up with you can end up with a buildup of olanzapine and potentially a adverse drug effect. But say haloperidol is actually metabolized by 1A2, 2D6, 3A4. You ding your 1A2, you still have 2D6 and 3A4 to back you up. And there are many other types of classes of drugs where you can try to kind of learn about which ones are a little bit safer, well, not necessarily safer, but at least have diversified their metabolism, so you know when to really get worried and when not. The second thing that's the big tip for today is bioavailability. And I really hope that I can impress upon you the importance of bioavailability today. So pharmacokinetic drug-drug interactions, as I briefly just kind of went over, there are 4 main stages: absorption, distribution, metabolism, and elimination. But in terms of clinically significant drug-drug interactions, really we're talking about absorption, metabolism, and elimination. We're going to do it with cases, so I hope that you guys will participate. So you're in a Falls clinic. You have an 80-year-old lady with excellent function who admits to poor oral intake of calcium. Her calcium is low, and that's corrected for albumin. And she asks you, which supplement should she be on? Medications include acetaminophen, amlodipine, and ranitidine. Answer? It doesn't matter. Calcium carbonate or calcium citrate. So raise your hand. Doesn't matter. Okay, people think it matters. So calcium carbonate. And last is calcium citrate. All right, we got some hands. Okay, so people chose calcium citrate. Can someone tell me why? Why do people pick calcium citrate? For those that raised their hands. Okay, we'll go over that then. So we're talking really absorption. So this is the phase when the drug is entering the systemic circulation. And as you see, there are many different ways that we can get drugs into our system. We can inject it, we can eat it, we can inhale it, we can put it sublingual, rectal, transdermal. There are many different ways. Bioavailability is an important concept, and that is the proportion of drug that actually enters the systemic circulation. Okay, so if you give it through IV, bioavailability will be 100%, right? You're injecting it directly right into the bloodstream, right into the systemic circulation. What about if you swallow the pill? What happens then? Well, there's lots of factors, and there's lots of steps to it. So the first stage when you take a pill is that the drug has to be liberated from either the capsule or the tablet form. Then, in order to actually get absorbed, it actually has to get to the area where you have the most absorptive surface area. And that's not the stomach, that's actually the small bowel. Okay, so you need some kind of gastric and intestinal motility to get you there. And then finally, when you get to that membrane, when you get to that small bowel, and you're ready to go across, there's kind of a couple factors. So one is you can just slip right through, okay? So, and that depends, and a couple factors that will affect that is how big are you, in terms of the drug, you being the drug. How charged are you, how much do you like water? There are a couple of different aspects. But then even if you do get through, there's two things that can happen to you as well. One is you can get spit right back out into the gut lumen, and that's through drug transporters, for example, P-glycoprotein, or you can actually be metabolized immediately before you get into any bloodstream. So in terms of with calcium absorption, calcium carbonate requires an acidic milieu for absorption. An H2 blocker and other antacids can increase the gastric pH. And some studies, now this was done more on kind of older patients, otherwise healthy, but totally achloritic. But what they did find was that bioavailability was decreased by about 30% for calcium carbonate, okay? So how can you get around this? So you can either take calcium citrate, like some people put up their hands, or you can actually induce some kind of acid secretion, even just a little bit more, by taking it with food, taking it with meals. And nice bioavailability studies have shown that even though you're on an antacid or you have absolutely no acid in your stomach, you take it with food, your bioavailability is back to normal. So that's a nice solution. So 1 week later, you receive a call from the patient's daughter. Because she went to Costco before and already bought a gigantic thing of calcium carbonate, she's going to use that, and she's going to take it with meals. Now, she also stopped her ranitidine, and she's using Gaviscon for her dyspepsia instead. She was enlightened by your discussion about drugs, and she wanted to run something by you. She has a urinary tract infection, and she was prescribed ciprofloxacin. Are there any issues with this? I see nodding. Anyone? Okay, well, fluoroquinolones can form inactive quinolone chelate complexes with cations, so things with a positive charge. So calcium, iron, aluminum, and zinc. And so your bioavailability can actually decrease, and we do have studies looking specifically at ciprofloxacin. When you take calcium carbonate and ciprofloxacin together, your bioavailability decreases by 40%. So you get 40% less. Aluminum hydroxide, which actually happens to be in Gaviscon, it decreases by 85%. So what do we do? Well, we actually have nice evidence that shows it's okay. Let's just separate it just by at least 2 hours. Some pharmacists recommend even 3 to 4 hours. It depends on the medication. But that's when we consult our kind of pharmacist colleagues, they do a lot of this counseling that we don't know about when we just prescribe the medication. but it is something that we should know about. So we tell her that, hey, look, Gaviscon contains aluminum and magnesium, both cations, and the patient's also on calcium carbonate supplementation, an extra cation. So if you take it together with the ciprofloxacin, you can actually decrease the bioavailability as well as the effectiveness, just space it apart. Okay, so that's absorption. Any questions so far? Good. So case 2 is Mrs. A, an 86-year-old lady from home who presents to the emerge after falling. She's on felodipine, risedronate, simvastatin, acetaminophen PRN, and vitamin D. Collateral confirms that she's very adherent to her long-term medications, but she says her muscles are sore and she's hypotensive. What happened? Muscles are sore.
Myopathy.
Thank you. That's one. And what about the hypotension? Yeah, and it's from drugs, like this talk, right? Drug-drug interaction. She started a grapefruit cleanse yesterday, of course. I see a couple of people drinking grapefruit juice. It's fine. Drink it now. So what happened? So again, this is also about bioavailability. We're talking about, again, it's the proportion of drug absorbed into the systemic circulation. As I mentioned, there's some drug metabolism that happens during the absorption process. We sometimes call it we commonly call it the first pass, okay? So the same slide from before, but go all the way down, and drug metabolism is part of this whole process. So, metabolism of the drug can occur before it reaches the systemic circulation, either in the small bowel, but where does all the blood that drains from the intestine go? Where is its first stop? The liver. A big metropolis of cytochrome P450 enzymes. It's like where you go, right? And that's where you can get metabolized. And so even before it kind of goes to your brain and everything, there's a lot of metabolism that can actually occur already. This is the first pass effect. Simvastatin and felodipine are metabolized by 3A4. Grapefruit juice, or grapefruits, block the 3A4 in the gut wall. And interestingly, not so much in the liver. And anyone from Western or London? So Straw and Clim Farm, discovered by Dr. Bailey. There's kind of cool stories about how he figured that out, but yeah, Canadian discovery there. So it actually, and that was more with the felodipine, the grapefruit juice. So we know that with grapefruit juice, your absorption of simvastatin can increase by at least 10-fold. Some of you can quote about 15-fold, and felodipine 2 to 3%, which is clinically significant. This is a nice picture that I took from Dresser, also from University of Western Ontario, which is published in the CMAJ. Definitely worth a read. It's from 2004. And recently there's another paper that was just, I think it was just from either last year or this year, also in the CMAJ. Very nice pictures as well. So, where's mouse? Mouse? Here we go. So, the drug is absorbed, 100% of it. Nothing happens in the stomach, remember, not too much. Goes into the small bowel. And if you just take a look, here's this intestinal wall. Drug that kind of slips through gets instantly metabolized, so you have less. This now is in the kind of intestinal kind of bloodstream, goes first stop right to the liver, where just in case some of that got missed, you can metabolize a little bit more, okay? Here's a table. Remember, don't write it all down, www.drug-interactions.com. Okay, this is already a little bit more condensed, but in terms of substrates, so drugs that are metabolized by 3A4, we have our statins like atorvastatin, lovastatin, simvastatin, ALS, not pravastatin, not rosuvastatin. I put benzodiazepines. I also slipped in zopiclone, my favorite non-benzo. Calcium channel blockers. Those include your dihydropyridines as well as your non-dihydropyridines. Your HRV meds and immune modulators. Things that can inhibit it. So under macrolides, you've got clarithromycin and erythromycin, but not azithromycin. So this is just for 3A4, remember. Antifungals, some CCBs, which are substrates, but they also inhibit their metabolism. Funny drugs, HIV meds, and here you got your grapefruit juice. I should also stick in pomelo as well as starfruit. And I found that out just from my parents who really liked pomelo. And they were on calcium channel blocker. And of course in amio. And then inducers, so anticonvulsants, rifampin, St. John's wort, and pio. So felodipine and simvastatin were the 3A4 substrates. Grapefruit juice inhibited your 3A4, so you had you had increased bioavailability of felodipine, hypotension. Increased bioavailability of your simvastatin, myalgias and rhabdo. Okay? But are all 3A4 substrates created equal? Do we have to avoid all calcium channel blockers? It's kind of impossible. Or are we going to avoid all, like, what are we going to do? Well, this is where bioavailability is kind of key. Drugs with low bioavailability are at increased risk of clinically significant drug-drug interactions. Let's just look at your dihydropyridine calcium channel blockers, okay, that are metabolized by 3A4. So after first pass, your bioavailability for amlodipine is 64 to 90%. It's not too bad. Nifedipine XL is 84 to 89%. But look at felodipine and nimodipine, pretty low, okay? So same picture. Let's just walk through it with amlodipine and felodipine. So amlodipine, we're going to take the bioavailability is 90%. Take 10 milligram tablet. After first pass, you end up with 9 milligrams. If you knock out that first pass, you get 10 milligrams. You get 10% more, 0.1 times more. Okay, not too bad. Look at felodipine here. 20% bioavailability, 10 milligram tablet, so you're really only left with 2 milligrams after first pass. You knock out that first pass, and holy smokes, look what you got here. You got a 5 times increase in your dose, okay? That's why this bioavailability is pretty important. So again, increase in systemic circulation drug levels is greater in drugs with low bioavailability, okay? So they're not created all equal. So statins, for example, if you look at the bioavailability of statins, it's not that impressive. So you look at your atorvastatin's 40%, simvastatin's less than 5%, so that one's really like a bit of a, just watch out for that one, and lovastatin 15%. Pravastatin, it's not a 3A4 substrate, but bioavailability is not that awesome either, and it's because there are other factors involved, like drug transporters. But also don't forget that phase 1 metabolism as you get older decreases in general by about 30%-ish, okay? Now, there are certain kind of nuances, and I'm happy to discuss them offline as well. So, for example, if you've got a patient just had a fresh kind of STEMI and you want to sparkle them for some reason, you really want to give them the sparkle dose of atorvastatin 80, which is a lot. In an older patient, you actually really only need to give them 60 milligrams in order to have the equivalent of what a younger patient would have at 80 milligrams. Okay, so just be aware of some of these issues. That's just because of normal aging, and that's without any drug-drug interaction. Okay? So, practical tips for this case. Cytochrome P450 enzymes, refer to www.drug-interactions.com. And then within a class, try to use the ones that are less likely to be involved in a 3A4 drug interaction. So in terms of juice, drink your grapefruit juice now when you're not on medication. So there's a big tub of that outside, and I'm going to be drinking that for sure. Because when I get older, I'm sure there's going to be something. But of course, in January, there is some press about the magical grapefruit that doesn't have the furanocoumarins that will inhibit your 3A4. I know, sounds awesome, but guess what? They don't have a good name. It's not ruby red, it's not pink, it doesn't sound cute yet. It's called UF914, and there's only 3 trees right now. So you need at least 7 years until you actually get it commercially produced. So it's going to take some time. For our generation here, we can drink up now, and then when we get older, hopefully this UF914 will end up being something that we can tolerate later. In terms of macrolides, azithromycin is not a 3A4 inhibitor, and statins, pravastatin is not a 3A4 substrate. So, but beware the drugs with low bioavailability. Very easy to check. You go into the blurb of clinical pharmacology of a drug, and usually it's in the first paragraph. Just use your search function, look bioavailability, and you click it, and you can find out what is it. Is it high? Is it low? Next case. Mr. M is an 80-year-old man with diabetes, hypertension, dyslipidemia, BPH, osteoarthritis, comes to the emerge with decreased level of consciousness. Here are his medications. Glyburide, stable for 5 years. Ramipril, tamsulosin, pravastatin, acetaminophen. Any thoughts? These are his meds.
Is he hypoglycemic?
Ah, excellent. And you check the list of ODB medications for Ontario Drug Benefit, or the equivalent in your respective provinces. I'm really embarrassed to say I forget the one in BC now. But anyways, urinary tract infection was recently successfully treated with sulfamethoxazole trimethoprim just last week. Any other thoughts? Glucose was 1.5. Very good for those. So no change in diet or chronic medications, though. He's pretty stable. So what happened? Kidneys. So kidneys could be one. Very good. Anything else? Excellent. Sulfamethoxazole, trimethoprim, fantastic. Glyburide and the sulfamethoxazole. It's a drug-drug interaction. Now I'm going to, since you're doing so well, is it pharmacokinetic? Pharmacodynamic? Pharmacokinetic, what the drug does to the body. So excellent. So metabolism was one key word, and also glucose metabolism. So very good. So it does have a pharmacokinetic drug interaction. So glyburide is sulfonylurea, and it inhibits your ATP-dependent potassium channels in beta islet pancreatic cells to increase insulin secretion. It's metabolized by 2C9. And then the insulin that you secrete is renally cleared. So we have lots of good answers here. Sulfamethoxazole inhibits 2C9. So you don't metabolize as much glyburide, you get more insulin, hypoglycemia. So metabolism is a biotransformation of a drug, and we commonly think of it as it stops a drug effect. And in this case, that's the case, right? It inactivates the drug. But sometimes it can also start a drug's effect, as in the case of a prodrug, like codeine, tamoxifen, clopidogrel. They're useless until you metabolize them. Then sometimes you metabolize the drug, but guess what? The metabolite's still active, like venlafaxine, risperidone. So that's something to be aware of. Phase 1 is where the cytochrome P450s hang out, alcohol and aldehyde dehydrogenase as well. And it does change with age in general by about 30%. Phase 2 is when you kind of stick either a sugar or amino acid or some glutathione on the side so that you can promote its renal excretion. And in terms of changes with aging, not so much. So here's a more condensed table. This is for 2C9. So substrates include sulfonylureas, S-warfarin, so that is the enantiomer that's actually active, S for serious anticoagulant, remember? Phenytones, 2C9, 2C19, but because it's got such a narrow therapeutic index, I just want to include it. NSAIDs, rosuvastatin, so not 3A4, but it is 2C9. These are the inhibitors, sulfamethoxazole, fluconazole, isoniazid, and metronidazole, and then inducers would be rifampin. Rifampin induces lots of drugs, just remember that. So is there another drug interaction? That's what I was pushing you for. Let's play a matching game, okay? What is similar between sulfamethoxazole and the sulfonylureas, glyburide, and glycoside? And I can put more of the other sulfonylureas, but excellent. Oops. So I circled them for you. Sulfonamide group. So even if you don't know all the structures, that's okay. Just look at the name, and it kind of gives you a bit of a reminder, okay? Well, actually, sulfamethoxazole can independently increase insulin secretion via the pancreatic beta cells. So it acts like a sulfonylurea, and it can actually independently cause hypoglycemia. We actually have nice case series of these in the literature. And the risk of this is increased in those with impaired renal function. So I'm going to preface this slide by saying trimethoprim, sulfamethoxazole, that combination has saved the lives of hundreds of thousands, probably millions of people around the world. Okay, there are clear indications for it. PCP, toxo, xenotrophomonas, MRSA infections, absolutely. But it is also the #1 prescribed medication for uncomplicated cystitis as well in women. And there are a host of complications associated with this medication, some which are uncommon, some not so much, and some which can actually be very serious. I'm going to quickly walk you through it. I like to use this mnemonic, not risky, and N for neurologic. So in the literature, it's been described some with mainly extrapyramidal symptoms and movement disorders that have kind of stopped afterwards, but very rare. But just to let you know, it exists in the literature. Oxygen carrying capacities and other hematologic toxicities. So examples would be oxidative hemolysis, methemoglobinemia, immune-mediated phenomenon like ITP, and also it can just suppress the hematopoiesis as well. T for toxic epidermal necrolysis and drug hypersensitivity disorders. We commonly think of Stevens-Johnson. They're quite rare, but it does happen. Reproductive, so this is when there was an observational study that compared women who had taken sulfamethoxazole trimethoprim and other antibiotics. So these women all had infections of some sort. There was a finding that perhaps there was slightly lower birth weight, and this was mainly in the first trimester. Next would be, and of course there are the risks in terms of with neural tube defects and stuff because there is a folic acid mechanism. Finally, interactions between drugs, like the talk from today. S for sugar, hypoglycemia, alone and as a drug-drug interaction. K, hyperkalemia. So it's the trimethoprim part that acts, it's structurally similar to triamterene, which is a potassium-sparing diuretic, right? So it can also cause hyperkalemia as well. Higher risk in older patients and especially those that have renal impairment. And then the Y is, why not choose an alternative antibiotic? So practical tips from this case, 2C9, look at that website. For those that are older than 65 years of age, check Ontario Drug Benefit kind of list or your respective provincial list. And sulfonylureas and sulfamethoxazoles can produce a drug-drug interaction, pharmacokinetic and pharmacodynamic. Last case, very quickly. 80-year-old lady who comes with a GI bleed. She's on AFib, previous TIA, hypertension, dyslipidemia. Her medications include metoprolol, atorvastatin, ramipril, dabigatran, omeprazole, and she had a recent course of clarithromycin 5 days ago for bronchitis. She's followed by an anticoagulation clinic, very adherent to her meds. On dabigatran, 110 milligrams PO BID, so the adjusted geriatric dose, if you will, for 4 months, and she's so happy about not needing to monitor her INR. What happened? She bled. So it's probably related to the dabigatran. So now we're really talking about excretion, getting the drug out of the body. It's mainly renal, and there's 2 ways that you can get a drug out of the body renally. One is passively, through glomerular filtration. You can estimate that with your Cockcroft-Galton, your MDRD. As you get older, once you hit 30, your renal function starts to go down. By how much? It's about 1 cc per minute per 1.73 meters squared per year, but after the age of 30. So I've already lost 4. So it's not going to make a big difference for me. But when I'm 90, if I get there, it is probably going to make a difference. So I'll have to be a little bit more aware. There's also active, so you can have drug transporters that sit in the kidney and actually pump drug out into the other urine. As you age, no real changes. Some studies suggest that it might increase. P-glycoprotein is just one of many drug transporters that I briefly want to discuss. It's a membrane glycoprotein that functions as a drug transporter, and its goal is to protect your body from xenobiotics, meaning anything that's not, like anything foreign, drugs especially. It's in your liver where it pumps bile into the feces. Pumps drug into the bile, which gets out through the feces. The gut, it pumps whatever drug gets absorbed right back into the gut lumen, so it gets pooped out. Blood-brain barrier protects your brain, pumps it out of the CNS, and renal tubule, it pumps drug out into the urine. So here's another kind of set of medications that are in your slides. And dabigatran, so it's an oral direct thrombin inhibitor. It's not metabolized by cytochrome P450. So that's awesome, right? Phew! Except, then you do due diligence, you read through the clim farm parts. And you're like, wow, bioavailability is only 7%. Holy smokes, there should be bells and whistles going on in your head right now, or like red flags or an alarm, okay? 7%, super low. It's a PGB substrate. It requires acidic milieu for dissolution too, distribution. Fine. Metabolism, it's actually a prodrug, so it needs to be metabolized by serine esterases before it actually works, and there is some phase 2 conjugation. But excretion is the key thing. Passively through glomerular filtration, which remember as you get older does decrease, and active through PGP. The half-life, interestingly enough, is if you've got a creatinine clearance of greater than 80, it's 8 to 13 hours, so that BID dosing makes sense. But as it gets as your creatinine clearance starts to decrease, the half-life increases. So just be aware of this, that if anyone's kind of below 50, that you have to start watching in terms of the half-life. It is contraindicated in those that are have a creatinine clearance of less than 30, but don't forget we have lots of patients that come in, and they may be fine, then they get acute renal failure and their kidney function really plummets. So remember to kind of hold it for a bit. So PGP in the small intestine pumps the dabigatran back into the intestine, so it decreases absorption. In the kidney, it pumps it into the urine, so it increases excretion. Clarithromycin is a PGP inhibitor. So it increases the absorption, decreases the excretion, you got higher levels of dabigatran, and you bleed. So, few other facts about dabigatran. There's no antidote. So unlike warfarin, you can't give FFP or Optiplex and be, all right, we're good. There's no lab test. So if your INR is 6 or even 9 and you're not bleeding, no one's going to, unlike warfarin where we're like, oh, okay, and we can take the appropriate action, there isn't such a thing for dabigatran. It's dialyzable, but dialysis is with its own risks and benefits. But if someone does overdose on it and they come in within 1.5 hours, you can give some activated charcoal. But that rarely happens because people usually present later. So in summary, what we talked about are drug-drug interactions today. 2 main types, pharmacodynamic, so they interfere at the site of action, and pharmacokinetic. And I hope that I impressed upon you that bioavailability is worth checking in our drugs. And just be aware that absorption, metabolism, and excretion are 3 different ways where you can have pharmacokinetic interactions. And thank you, and any questions? Okay. Oh, yeah.
We often in geriatrics prescribe standing time and also a lot of things, and there's an interaction I think you told us before with warfarin. Is that dose dependent, or is there anything?
Yeah, so that is. So that's a very good point. So that would be, so with warfarin. So basically with high dose Tylenol, the metabolite of Tylenol, one of them is the NAPK, the same way that causes kind of your toxic liver damage whenever you overdose on it. That specific metabolite also interferes with your gamma carboxylase, which is what actually activates a lot of your clotting factors. Excuse me. So what you end up doing is you can actually effectively increase your INR by taking a lot of Tylenol, which does, you can occasionally, you actually frequently see that in overdose patients. Their liver function may be okay, but their INR may actually be high, and you're like, oh no, they're failing, but it's like, oh, hold on, wait, So in patients on warfarin, we do know that there's a phenomenon that can actually happen. That would be a pharmacodynamic drug-drug interaction. And it is dose dependent. So there was a nice coagulation clinic study where they looked at patients that were stable on warfarin, and they gave them no acetaminophen, then 2 grams, 3 grams, 4 grams, and there was actually a nice dose response in terms of with an increase in INR. So something you do need to watch out. So that was from the previous talk. Had to change it up for this time. Any other questions? Okay.
I want to thank Joanne for an excellent presentation and getting us back on schedule and set this small token of our appreciation for filling in on such short notice. So thanks. Let's give Joanne another.
Restaurants aren't as good, but